to be giving you next Friday, because next Friday will sadly be Elliot's funeral. I've known Elliot for a very long time. In fact, it was thanks to Elliot that I was able to become a pediatric cardiac anatomist. This is a picture showing Elliot and myself in 1977. This was at a symposium, an international symposium that we organized, funded by British Heart Foundation and held in London. Subsequent to that, we organized many other symposiums. And Elliot was a great traveler and a wonderful talent spotter. Not only did he find me, he found others who set up a department at the Royal Brompton. We've lost several distinguished colleagues in the recent months, so it's very sad for me now also to lose Elliot. This means we're going to have to reorganize the session that I was due to give next Friday. Now, you will all also know that we've been running these classrooms now for the best part of 2020. And I think they have proved very popular. So I've been discussing this situation with Sasha and Grace. And what we've decided to do is to take next week's session, which we should have had next Friday, and we're going to start 2021 with this session, and we're going to slightly change the format of sessions because we are going to make them interactive classrooms. So if I show you the sessions that we've already arranged to begin in 2021, you'll see that what I am going to do is I am going to interact with my clinical colleagues. And we're going to be discussing with you anatomic features of note, and we're going to relate them to their clinical implications. And Saurabh Gupta and I, Saurabh from the All Year Institute in New Delhi, we'd already agreed that next Friday we would share the presentation. But what we're now going to do is we're going to defer that to the first of our presentations for 2021. So as you see, on January the 8th, Saurabh and I will be discussing with you, is there an artery of the fifth pharyngeal pouch? The following week, we'll work together again and we'll share with you our thoughts on the sinus venosus defect. In the week after that, I'm going to be joined by Grace. And Grace is going to share with you a recent case that she and her colleagues dealt with in their own center. And we're going to use that to focus on the optimal definition of hyperplastic left heart syndrome. And then to finish the first month of January, I'm pleased to tell you that I'll be joined by Krishna Iyer, the surgeon also working in India at Escorts. And Krishna and I will be discussing double outlet from both ventricles. So we hope that these interactive classrooms will prove just as popular with you as have my own classrooms, which you have been following throughout the better part of 2020. We'll judge how things go on at the beginning of 2021, and if you like them, we will continue them. So it is down to you. And now we will get on and we'll finish our presentations for 2020 with my consideration of aortic rings and slings.
Hi, everybody. Welcome to Congenital Heart Academy. After this amazing announcement from Dr. Anderson, I'm happy to share with you a few announcements before we start with today's classroom. And I want to thank again Dr. Anderson for doing that and Dr. Silverman for joining us today again. So I'm sure the discussion is going to be awesome. Please follow us on social media, then you're going to be able to see everything that we are preparing for you. And this classroom is going to be recorded and published on YouTube. So please register and subscribe to our YouTube channel. And then you're going to be able to see this presentation again and share with your colleagues if you think it's going to be important for them. Today is the last day of the PCICS meeting. So if you haven't joined this meeting yet, please do so. We had amazing topics, and today I'm sure it's going to be still very good topics. If you live in one of these countries, you can join this meeting for free and get 1 year of PCICS membership for free as well. So you can scan this QR code and take a look on that. And all the talks are going to be available for some weeks, so you can catch up with all the talks if you didn't have the chance in the last 2 days. Today we have our last talk from Dr. Anderson of this amazing series, and we are going to continue next year. On Monday, Dr. Norman Silverman is going to talk about anomalous pulmonary venous connections and do the correlation between echo images and morphology. This is going to be awesome. Please join us. And Dr. Silverman has amazing things for us for next year as well. And then to close up the year, we are going to have updates on fetal cardiology on December the 17th. After that, we are going to take few weeks of vacation, and we really want to thank all of you for joining us during this year, all of you who had attended our meetings, to our faculty who gave their time and their knowledge and their experience to share with all of us, and to the delegates from Congenital Heart Academy that had helped us a lot as well. And as you could see by Dr. Anderson's talk, 2021 is going to be awesome, a lot of things to come, and hopefully we are going to be able to see each other in person as soon. So now we are going to start with Dr. Anderson's talk. Thank you guys for joining us. And please type your questions on the Q&A chat box. Sasha, have you started? Because I don't hear anything.
So, vascular rings and slings. You're all aware that there are multiple ways in which the extrapericardial arteries can encircle the tracheoesophageal pedicle. And if we are to understand that variation, we come back to the Edwards hypothetical double arch. It's amazing how well this concept has stood the passage of time. But if we are to interpret the anatomical background to the Edwards hypothetical arch, if we are to understand the remodeling of pharyngeal arch arteries, we also need to take into account the way that they develop. And over the years, we've interpreted this development on the basis of the Rathke diagram. If you look at the original publication, you'll see that this appeared in 1857. So it too has withstood reasonably well the passage of time. So here we see the idealized diagram. This is our version of the Rathke diagram. We see at the front the aortic sac. Arising from the aortic sac, we have a series of 4 arteries that percolate through the pharyngeal mesenchyme. And in the diagram, these are shown all being present at the same time. We then see in the Rathke diagram that we have a 5th set of arteries, but you will note that they have a dotted line within them, and I put a question mark against them. Then we have an additional set. Because of that set with the dotted line through them in the Rathke diagram, we have to call these the 6th arteries. Additionally, we have the 7th cervical intersegmental artery. And you will remember from last week when we just discussed coarctation and interruption, this intersegmental artery is particularly important because it becomes the subclavian artery. And we're going to be discussing that again today. So from the Rathke diagram, we can learn that the developing arch system initially is bilaterally symmetrical. There's no doubt about that. But we have to now ask questions. Do we ever see 6 sets of arches at the same time? More importantly, is there ever a 5th pharyngeal arch? If there's no 5th pharyngeal arch, then obviously there cannot be a 5th arch artery. And I've already told you that at the beginning of next year, Saurabh Gupta and I are going to discuss together whether or not there's a 5th arch artery. But I'm going to set the scene for that discussion today when I'm going to show you that in fact there never is a 5th pharyngeal arch. Because what I'm now going to share with you relative to vascular rings and slings, also relative to the discussion of the 5th pharyngeal arch, is the evidence we now have from developing embryos. And we're going to be looking not only at developing human embryos, as we have been doing over recent weeks, we're going to compare that, again, as we have been doing, with what happens in the developing mouse. So here is a picture from a developing mouse embryo. For all of these pictures I'm going to show you to develop today from the murine heart, I'm indebted to Simon Bamforth. Simon is senior lecturer in the Biosciences Institute of the University of Newcastle, where I am also still the visiting professorial fellow. And I've been working together with Simon on these issues now for the best part of 10 years. And I'm indebted to Simon for making these exquisite reconstructions. What he has done, he's taken the episcopic data sets prepared by Tim Mohan. You've been seeing those also in several presentations. But this time, Simon has reconstructed the arteries running through the pharyngeal arches. So in this particular embryo, you see its embryonic day, 9.5. We also count the somites because that gives us an accurate estimation of how the embryo is growing. And there, within the body of the embryo, you see the developing heart tube. And there you see the first pharyngeal arch. And Simon, by reconstructing the developing arterial system, has shown that prominent artery running through the first pharyngeal arch. There you see the second pharyngeal arch, and you can see that there is an artery developing within that arch also. And they come together and they form the dorsal aorta. And had I shown it to you from the other side, you'd have seen the other set of arch arteries. So now we've gone on into embryonic day 10.5. This is early in embryonic day 10.5. The mouse has 32 somites. We can now see the top of the heart tube, which is forming the atrium. And now we can see the first and the second pharyngeal arches. But what you see now is that the arteries within those arches are beginning to regress. There has, however, been the addition now of further arches. So yeah, there you see the third pharyngeal arch, and indeed, the third arch artery is now the dominant artery. And you can see the beginning of development of the fourth pharyngeal arch and an artery beginning to appear also within that arch. Between them, we see the component of the dorsal aorta that we call the carotid duct. And that also can persist and be important in the developing of vascular rings, although we won't be discussing the carotid duct more today. If I now move on to the latter part of embryonic day 10.5, when the mouse has 40 somites, we can see that there has been significant additional development. The artery in the first arch by now has regressed completely. But there is the regressing artery of the second arch, and you see the artery again in the third arch, which we saw at the previous stage. We can now also see how the arches themselves are formed between outpouchings from the pharynx. So there is the third arch placed between the second pouch, the third pouch. We can then see the fourth arch placed between the third pouch, the fourth pouch, and you can now see that that segment of the dorsal aorta that we called the carotid duct is also beginning to regress. But now there has been a significant additional development, because we have a further set of arch arteries that has developed within the pharyngeal mesenchyme, but this set of arch arteries does not have a pouch behind it. So we only have 4 pharyngeal pouches, and that means we have 5 sets of arch arteries. It also means that never do we have that alleged 5th pharyngeal arch arteries, because we never have a 5th pharyngeal arch. And we'll discuss that again, as I've mentioned to you already, at the beginning of our sessions for 2021. So let's now move from the murine embryo and let's make comparisons with what is going on in the developing human embryo. And you will all know by now that I'm depending for this information on the interactive PD files that have been made by Professor Wout Lammers, Dr. Jill Hickspoors, working in the University of Maastricht. Since we started our discussions, however, Jill and Wout have improved still further these interactive files. So now I'm going to be showing you the latest version of these files. And as you will see, they permit me to take apart the developing embryo so that you can see the significant components. So here we're looking at the embryo from its left side, comparative to the view we saw of the mouse embryo. And Wout and Jill have reconstructed in gray those outpouchings from the pharynx. They almost reach to the outer surface of the embryo, and if we put the outer surface in, we'd see ectodermal clefts there, but they don't quite go all the way through, so they are pouches. And there you see the first pouch, and already the artery that ran through the first arch has disappeared. There you see the second pouch, and the artery that initially percolated through the second arch has also disappeared. But now we see between the second pouch and the third pouch, the artery that is the third arch artery. And then we see the fourth pouch, permitting us to recognize the fourth arch artery. And as in the mouse, we then have a pulmonary arch artery. As I've commented, we're calling that the pulmonary arch artery because there are only 5 arches. So it would make no sense now to call this the 6th arch artery, although that is the terminology that you're used to. But I hope you will understand if I call this the pulmonary arch artery. And it does not have a pouch behind it. So this now shows you the beauty of having these interactive files, because this is the same data set. It's the reconstruction made by Jill and Wout. And what I've done is I've taken away the neural tube so that you can see the pharynx from behind. There is the entirety of pharynx in gray, and it shows you very beautifully now the pouches. And you see that they truly are outpouchings from the cavity of the pharynx. And there are 4 of them. You see that the arteries percolating through them come together posteriorly, and they form the dorsal aortas. And you also now see how this connection between the arch arteries, the dorsal aortas, is encircling the esophagus. And growing forward from the esophagus, the developing trachea. And it is this encirclement of the tracheo-esophageal pedicle by the system of extrapericardial arch arteries that is going to permit us to understand Edwards' hypothetical double arch. There you see the junction between the arch arteries and the dorsal aortas, confirming that at this early stage the system is bilaterally symmetrical. And you also see the location of the 7th cervical intersegmental arteries. And as you know, they will become important as they become the subclavian artery. So we can confirm the bilateral symmetry if we return for a moment to the developing mouse heart, back to Simon's reconstructions, because I want to emphasize to you that the aortic sac now, the cranial part of the aortic sac, has divided into 2 horns. And each of these horns is giving rise first to a 4th arch artery, moving cranially, a 3rd arch artery. And in this mouse, you can still see the regressing 2nd arch arteries. Arising caudally from the aortic sac, we have those pulmonary arch arteries. And Simon has reconstructed the right and left pulmonary arteries themselves that are developing within the pharyngeal mesenchyme. As yet, they have yet to make contact with the pulmonary arch arteries. We can see the symmetry of the dorsal aortas, and then caudally you see the 7th cervical intersegmental arteries. So let's return to that human data set that I showed you at Carnegie stage. In fact, I've moved on now to Carnegie stage 17 because I want to show you what happens as this system remodels. Here, again, we're looking at it from the left side. And now I've also taken some of the information to tell us what's happening within the pericardium. So within the pericardium now, by this stage, the middle part of the outflow tract has divided to form the separating aortic and pulmonary roots. And in purple there, you see the swellings that will form the non-adjacent leaflets, the non-adjacent sinuses of the aortic and the pulmonary roots. In this refined version of the interactive PDFs, Jill has also reconstructed the pericardial reflections, because you will remember from our earlier discussions how important it is to distinguish what is intrapericardial as opposed to what is extrapericardial. So now, here on the aortic side, you can distinguish between the intrapericardial, the extrapericardial aorta. And you see now how the extrapericardial aorta is dividing into the 2 horns of the aortic sac. We'll come back to the left horn in just a moment. If we concentrate on the right horn, we see that it gives rise to the right 3rd artery, the right 4th arch artery. But note now how the right 4th arch artery, note that color, it's going to retain that color, it's joining with something that is red. And the red part is the right dorsal aorta. But now you see the beginning of cranial migration of the right cervical intersegmental artery. As we discussed, in fact, this is due to caudal migration of the heart, but the end result is that the right 7th cervical intersegmental artery is moving up the right dorsal aorta. So now we have a caudal part that meets the left dorsal aorta. So let's move back to the left side, because we see now developing left side is being supported by the left horn. The left horn is giving rise to the left 3rd arch artery, the left 4th arch artery. And as on the right side, the left 4th arch artery is joining the descending aorta. But the descending aorta is also now receiving a contribution from the pulmonary side. Because we can see the location of the pericardial reflections, we see that the pulmonary trunk, derived from the distal non-myocardial outflow tract, is exclusively intrapericardial. And it gives rise to the caudal part of the aortic sac, And now, by CS17, 40 days of development, the pulmonary arteries have joined up to the bases of the pulmonary arch arteries. The left pulmonary arch artery is now becoming dominant, and it is joining together with the left fourth arch artery to form the left dorsal aorta. And there on the right side, you can see the right pulmonary arch artery, and you see it is diminishing in size relative to its left-sided counterpart. But on the left side, you can also see that the left seventh cervical intersegmental artery is beginning to track cranially relative to the developing heart. So let's move the whole thing round. We're still at CS17, 40 days of development, but now we're looking at the same thing from the front and from the right side. So again, you see the separate arterial roots, you see the pericardial reflections. You see how those pericardial reflections are dividing the ascending aorta into its intrapericardial part, developed from the non-myocardial distal outflow tract, the extrapericardial part, which represents the cranial part of the aortic sac. And then the cranial part of the aortic sac is developing into its two horns. And now we can see how the horns are branching. On the right side, we see the right third arch artery, the right fourth arch artery, and now as we see it from the right side, we see how the right fourth arch artery becomes continuous with right dorsal aorta, and how the seventh cervical intersegmental artery has moved up right dorsal aorta. And now we know that eventually this right pulmonary arch artery will disappear. And if we turn it round and we take it a step further, we can see exactly what's happened. So now I've taken you to Carnegie stage 20, 49 days, 7 weeks of development. And we're now virtually at the postnatal situation, although there are still changes to take place in the formation of the subclavian artery. But what we see again, the pericardial reflections, we see the extrapericardial aorta. You will remember that is the cranial part of the aortic sac. But look now what has happened to the horns of the sac, because the right horn is now small compared to the left horn. The right horn is giving rise to the right third arch artery, continuing as the right fourth arch artery, and then supporting the right seventh cervical intersegmental artery, which now has become incorporated as the developing subclavian artery. The left horn is much bigger, and it gives rise to the left third arch artery. The left fourth arch artery is now a segment of what will become the transverse aortic arch. And that is because the left seventh cervical intersegmental artery has migrated above the zone of union between the left pulmonary arch artery and the dorsal aorta. So now we can recognize for the first time the aortic isthmus. And you'll remember we discussed this castling process of the seventh cervical intersegmental artery and left pulmonary arch artery in the setting of aortic coarctation. We can turn the whole thing around and we can look at it again from the right side, a little bit obliquely. We can see once more the pericardial reflections, intrapericardial aorta, extrapericardial aorta, and now look at what has happened to that right horn of the aortic sac. It's going to be the brachiocephalic artery. It's giving rise to the right third arch artery, a segment of the right fourth arch artery, and there now you see the two parts of the right seventh cervical intersegmental artery, because part of that is going to become the vertebral artery, the other part will be the subclavian artery. So let's now turn to the definitive situation, and let's see where these parts have come from during development. I've drawn in the pericardial reflections, and now you can see how the first part of the extrapericardial aorta is that cranial part of the aortic sac. You see how the right horn is now recognizable as the brachiocephalic artery, The right subclavian artery, its initial part is the right fourth arch artery. Its distal part is the seventh cervical intersegmental artery. The common carotid arteries on each side are derived from the third arch arteries, but the left horn of the sac has become the first part of the transverse aortic arch. It is then the left fourth arch artery that forms the second component of the transverse arch, with the left subclavian artery now having castled over the union between the arterial duct and the descending aorta. The pulmonary arteries derived from the caudal part of the aortic sac now continue as the arterial duct, which of course is the remnant of the left pulmonary arch artery. What that means is that we can now recognize the isthmus, and we can also see that these components of the right side have now disappeared. But what we're also going to see is that it is persistence of those right-sided components that is the essence of understanding vascular rings. Let's look at the definitive situation first. Let's put in again the pericardial reflections. Let's remind you the aorta has an intrapericardial part, an extrapericardial part, whereas the pulmonary trunk is exclusively intrapericardial. And that, of course, is because the pulmonary trunk is the entirety of the pulmonary component of the distal non-myocardial outflow tract. Right pulmonary artery, the left pulmonary artery, were those vessels developing within the pharyngeal mesenchyme. So there again, brachiocephalic artery, the right horn of the aortic sac, the left common carotid artery, third arch, the left subclavian artery, the seventh cervical intersegmental artery, with that small segment forming the second part of the transverse arch, representing the component of the fourth arch artery. And then we see the isthmus, the space between the, or rather the component of the systemic pathway between the origin of the left subclavian artery, the junction between the arterial duct and the descending aorta. So hopefully that sets us up to understand vascular rings, which represent the persistence of those developmental primordiums. And to understand vascular rings, we need to come to Edwards' hypothetical double arch. Because as far as I'm aware, it accounts for all variations, not only vascular rings, but also isolation brachiocephalic arteries. And it is amazing that we can go back. We see that this concept appeared in 1948. Jesse Edwards was the consummate cardiac pathologist. My very good friend and colleague Anton Becker trained with Jesse Edwards, and I was fortunate that Anton was able to share with me many of the jewels of wisdom that came down from Jesse Edwards. He was a true cardiac pathologist, and his concept of hypothetical double arch is perhaps the thing now that we remember most about him. But he was an all-round cardiac pathologist. So here is his double arch. There you see the aorta, which gives rise to the left arch, right arch. The two arches come together and they form a neutral descending aorta. Arising from the cranial aspect of each arch, we have first a common carotid artery and then a subclavian artery. Arising from the underside of each arch, we then have an arterial duct. And should this persist in its entirety, then it encircles the tracheo-esophageal pedicle. This is the nicest example I have ever seen of a hypothetical double arch. It is not quite complete, but let's look at what's going on. As there is the aorta, and as Edwards hypothesized, it gives rise to a right arch, it gives rise to a left arch, and it forms a neutral descending aorta. Arising from the right arch, with the two components having encircled the tracheoesophageal pedicle. We have a right common carotid artery, we have a right subclavian artery, and then arising from the left arch, we have a left common carotid artery and a left subclavian artery. And there, also arising from the undersurface of the left arch, we have an arterial duct. So all that remains to produce the hypothetical double arch is a right-sided arterial duct. But to the best of my knowledge, we have never seen a complete example of the Edwards hypothetical double arch. I think this is close as we can get. So how do we account for all the multiple variations? What Edwards pointed out is that this double arch system can be divided at any point, made up by those linking components of the extrapericardial arteries that we have seen during normal development. So the double arch system can be divided between the cranial part of the aortic sac and the origin of the third arch artery. And you'll remember this is the right horn of the aortic sac. It can be divided between the origin of the right third arch artery, the right fourth arch artery. And you'll remember that this is a component of the right fourth arch artery. It can be divided at the site of the right dorsal aorta. And in most instances, we do not have a right-sided arterial duct, but it can persist. And then if we look at the left side, we can have division at the site of the left horn of the aortic sac. We can have division of that component of the fourth arch, forming the second part of the transverse arch. Or we can have division of the left dorsal aorta. And of course, we can have the left-sided arterial duct either disappearing or present in ligamentous form. So let's look at perhaps the commonest example of persistence of these bilateral primordiums, and this does not always produce a complete ring. So what we have here is division of the right arch distal to the right common carotid artery. That means the left arch is going to be dominant, and it's going to feed the right subclavian artery in retroesophageal fashion. And we know that that dorsal part of the right aorta can then persist in somewhat enlarged fashion, and we call that the diverticulum comerale. So how do we explain that? Well, let me take you back to the human embryo at Carnegie stage 17. And in fact, for all the variations in the vascular rings, we can account for them on the basis of what I'm going to show you here, although obviously we have to account for differing segments disappearing. So there you see the right common carotid artery. And there you see the right subclavian artery. So what is it that should be present to join them up during development? And that is the segment of the fourth arch artery, the seventh cervical intersegmental artery, and the right pulmonary arch artery. So if all of those components regress, then we will have the right subclavian artery fed by the persisting dorsal component of the right arch, which will become the diverticulum comerale. And then, of course, the left arch will be dominant. And that's exactly what we see with retroesophageal origin of the right subclavian artery. So here I'm showing you an example from behind. There you see the left arch. Its branch is the left subclavian artery. But when we have retroesophageal origin of the right subclavian artery, it now is the last branch of the aortic system, and its proximal part is somewhat enlarged as the diverticulum comerale. And we can make an inference here that when we have the diverticulum of comerale, that implies that initially there was flow through the subclavian artery through an arterial duct, and the same goes on the other side. So we can also explain right aortic arch, and of course this does not produce a vascular ring. So when we have a right aortic arch, it is the left component of the dorsal aorta rather than the right component that has regressed. And then of course, on the right side, we may have regression of the left-sided arterial duct, and we would expect the arterial duct in this situation to be right-sided, arising from the right arch. But paradoxically, when we have right arch, more usually we find an arterial duct taking its origin from the brachiocephalic artery, which itself is left-sided. You can, of course, have a right-sided arterial duct, but it is persistence of that left-sided arterial duct, but with separation between the left common carotid, the left subclavian artery, that is the commonest example of the vascular ring. And here we see the picture of that showing us how we explain it on the basis of Edwards' hypothetical double arch. Because we have separation in the left arch, the right arch is now dominant, and there is the regression of the component of the left arch. And the regression is between the left common carotid artery, the left subclavian artery. But now we have a ring because there is also persistence of the left-sided arterial duct. And there you see the left dorsal aorta, which remains patent, which is enlarged, and which we see as the diverticulum of Commerell. That's how we see it. Let's look at it for real. So here is a nice example of the commonest form, in my experience, of vascular rings. There is the aorta. We have a right aortic arch. So the first branch of the aorta should be the brachiocephalic artery. But in this instance, the first branch is the left common carotid artery. And that is because the left-sided primordiums have become separated. There we should have origin of the left subclavian artery, but instead the left subclavian artery is arising from the pulmonary trunk. We can see that better if I now take the same specimen and I show you what it looks like when we photographed it from the left side. So there you see the pulmonary trunk, which is continuing as the arterial duct. The arterial duct is giving rise to the left subclavian artery, but in this instance, the left subclavian artery is also being fed by the diverticulum of Commerell from the right-sided aortic arch. And it is the persistence of the arterial duct that is encircling the tracheo-esophageal pedicle, giving us the vascular ring. And this, of course, is going to give us the symptoms that we associate with vascular rings. But then how do we explain interruption of the arteries? And it's very simple, using the same approach, Edwards' hypothetical double arch. So here we have a right arch, and now we have regression of the left-sided dorsal aorta. We also have regression of that segment of arch that should have been formed between the left common carotid, the left subclavian arteries. And you'll remember that was part of the fourth arch artery. So now we have the left subclavian artery, and it is isolated from the dorsal aorta. It's isolated from the right common carotid artery. But because of persistence of the left-sided arterial duct, it is put into continuity with the left pulmonary artery. And so here we see an example of what we call isolation of the left subclavian artery, right-sided aortic arch rather, so its first branch, left common carotid artery. We would expect that to be continuous as the left subclavian artery, but instead the segment of arch the segment of the fourth arch artery that should join the two has regressed during development, as has the segment of dorsal aorta. So now the left subclavian artery is isolated from its systemic components, but is attached by the left-sided arterial duct to the pulmonary trunk. And this is what we call isolation of the left subclavian artery. There can, of course, be isolation of the left common carotid artery, or there can be isolation of the brachiocephalic artery. And the same thing can happen on the right side. Now, everything that I've discussed with you thus far has presumed that those segments of the initial bilaterally symmetrical primordiums disappears completely. But you will all know that that is not always the case, because those segments can persist as atretic strands. And if we have those strands persisting, then the ring produced will be tighter, because each arch segment can persist as a fibrous cord, as obviously also can the arterial duct. So let's go back and let's look at that case I showed you originally. This, you will remember, I told you, is the commonest form that I've seen. Pulmonary trunk coexisting with the situation where there is separation between the left common carotid artery and left subclavian artery. But initially, of course, during development, there had been a segment present joining the two. It was that segment of the left fourth arch artery. What if that segment had not disappeared, but rather, like the arterial duct, which could become ligamentous, that arch segment had also become ligamentous? It would have produced a picture that would look like this. So in our artist rendition here, we are showing you the left common carotid artery, the left subclavian artery, which is retroesophageal, arising through a diverticulum of Commerell. But now I'm showing you what would happen if, instead of disappearing completely, that segment of the transverse arch derived from the fourth arch artery had persisted as a fibrous cord. Because now we'd have two fibrous cords producing a vascular ring. And this is key for the surgeon, because if the surgeon is sent in to relieve this situation, he or she must make sure that both of those strands are not present. And exactly the same thing pertains when we have persistence of a ductal diverticulum. And that exists again with right arch. But now the brachiocephalic artery is giving rise to its branches, both left common carotid, left subclavian artery. But now there is disappearance, or rather there is persistence of that arch segment between the brachiocephalic artery and the origin of the duct as a fibrous strand, and also persistence of the duct itself as an arterial ligament. So once more, we have two potential fibrous cords, and should the surgeon be sent in to relieve this variation, again, he must remember, or she must remember, that there can be two fibrous cords present. So what I hope I've shown you is that on the basis of what we now know about normal development, we can endorse Edwards' hypothetical double arch, because it accounts for all possibilities, but remember that possibility for dual constricting fibrous cords. So now we have to complete our discussion by considering this lesion. In this lesion, the right pulmonary artery arises from the left pulmonary artery. Sorry, the other way around. The left pulmonary artery arises from the right pulmonary artery, and as the left pulmonary artery makes its way to supply the left lung, it passes between the esophagus and the trachea. And almost always, this is associated with complete tracheal rings. And this, of course, is what we call the vascular sling rather than the vascular ring. And this has nothing to do with Edwards' hypothetical double arch, because the vascular sling is due to abnormal development of the trachea relative to those developing right and left pulmonary arteries. The Edwards hypothetical double arch, however, provides us with a rational explanation for the myriad examples of rings, various types, and also, as you have seen, for isolation of the brachiocephalic arteries. So that is going to complete our discussions for 2020. We do hope that you will join us again in 2021, and then we'll begin our interactive classrooms, because there is still so much we have to discuss about the anatomy of congenital cardiac malformations.
Thank you very much, Dr. Anderson. It was an amazing session as usual, and I think we are
okay,
closing.
Sasha, are you still there?
Sasha is coming. Can you hear me?
I can hear you.
Okay, good.
Yes, I'm here.
Okay, Sasha just needs
Sasha
to.
has the latter part of our recording of last week.
Okay, I just stopped it now. Yeah, good. Done. Okay, so thank you, Dr. Anderson. It was a very good session.
Hopefully you'll find that was satisfactory. Let me know if there are any problems. I'm going now to leave the meeting. Thank you for all.
Okay, we still have the sound of Sasha behind, but it's okay. We're finished now.
We'll be
I
together
can't
again
mute him.
Friday
Sorry
afternoon
for that, guys.
at 8 o'clock. Cheers.
Bye.
Okay, now we are done. So it was a very good session. I think we are closing 2020 with a very interesting topic. And to begin with, I'd like to listen to Dr. Silverman's comments and questions about this topic.
Well, Bob is still there. The one
I'm here.
I must say, there almost is. It's so clear, Bob, that almost nothing is left for questioning, because I think even the ligamentous nature of the things that become very difficult clinically to identify can only really be identified by the surgeon. And I think it still requires the art of surgical observation to deal with these rings. And many of them are associated with either respiratory or swallowing problems and present early in life. We now can identify many of these issues within the fetal examination, because the lung is filled with fluid, and so you get a much better look at the vascular structures than you would in the postnatal heart. My big question to you is, why does the left pulmonary artery, where it originates from the right pulmonary artery, run in front of the esophagus? And I think that I'm old enough, and many of the people that are listening may be old enough, that when we did a cardiac evaluation for cardiac catheterization, we always got a full series of chest x-rays. And in the chest x-ray, if the esophagus was indented posteriorly, that usually suggested some form of anomalous origin of the subclavian vessel. But when it came anteriorly, it was pulmonary. So why is it that the pulmonary vessel runs anterior to the esophagus?
The only explanation I can give is that both the right and left pulmonary arteries and the trachea are developing within the pharyngeal mesenchyme. And as I explained at the latter part of my presentation today, the sling is not due to remodeling of those pharyngeal arch arteries. It's something to do with the way all these structures are developing within the pharyngeal mesenchyme. I don't think anybody has looked into this as yet. I think it's one of the many things we still have to explore. I mean, as you've seen, I think that the the reconstructions we're now able to make of the developing human embryos give us so much information, and we can see what's happening with the rings, and we can make the inferences relative to the rings because it fits so well with the Edwards hypothetical double arch. I think we're going to have to think more about the sling, and we're going to have to explore in greater detail precisely how the trachea and how the trachea grows out, how the bronchuses grow out. Wout Lammers, in fact, is an overall embryologist. He knows far more about embryology than I do. So I shall pose to Wout the question he and Jill can perhaps look into the background of the pulmonary sling, because it is totally different from the rings. So I'll explore that with them, and we'll see if we can perhaps get some answers for that question, which is a very good question. And we'll try and address that next year. We'll see what Jill and Wout have to say.
Now, I know you have a session coming up on this, but there is this clinical entity, and I will just put it to you as a clinical entity of the so-called fifth artery. And in some of the patients, it's a double-barreled aortic arch. But in some patients, it's associated with coarctation. And I'd like to just hear your thoughts on that briefly, and to tell us about the upcoming lecture you're giving on this subject.
Well, again, it's a very good question that you ask, and you will know better than I that people all over the world are interpreting these things that they see, particularly double-barreled aorta. It was a double-barreled aorta that Van Praagh, our good friend Richard Van Praagh, first implicated as representing the fifth aortic arch. And it's a plausible explanation as to why you should have the double-barreled aorta. It falls, however, as I've shown you, because there's never a fifth pharyngeal arch. So if you never have a fifth pharyngeal arch, how on earth can you have a fifth pharyngeal arch artery? Now, paradoxically, Simon Bamforth and I looked at one human embryo, and we found a regressing structure that initially we thought might be a fifth arch artery. But we've revisited that. And we've had to do all of this because there was a very elegant presentation in 2019 by another colleague of mine called Anthony Graham, who is another embryologist. He works in London, and he and his colleagues are experts on the derivatives of the pharyngeal arches. And you discussed this last week. You discussed the remnants of the endodermal part of the pharyngeal arches. We were talking about the thyroid glands, the parathyroid glands. You made the point how they were third, fourth arch derivatives. We know that each pharyngeal arch has a nerve associated with it. It has cartilage associated with it, but there ain't no cartilage, nerve, endoderm for a fifth arch because there isn't a fifth aortic arch. So what Saurabh and I will be doing when we resume our discussions in January, we'll be showing you that these entities, as you say, they do exist, but we now think we can find far better explanations for them, particularly the double-barreled aorta. The double-barreled aorta is very easy to explain simply on the basis of collateral channels. But we also think that there is so much remodeling that takes place during normal development. There are so many what we call normal variation, not even abnormalities. There is so much remodeling that goes on for the derivatives that make those various structures. We believe that the majority of the so-called fifth arch arteries can better be described on the basis of remodeling of the aortic sac and the pharyngeal arch arteries. It means, however, that we've got to stop calling the arterial duct the sixth arch artery. And that's why throughout the presentation today, I spoke about the pharyngeal arch artery. Because if there isn't a fifth arch, obviously the artery that gives rise to the arterial duct is the fifth arch artery, but it would be totally confusing if we tried to call it the fifth arch artery. That's why I'm hoping we can call it the pulmonary arch artery. But we will be giving this detailed consideration on our first series of 2021, and we'll be doing that on January the 8th.
So it's just that we're left with the same problem that we always left with an inappropriate nomenclature which everybody uses. That's the problem.
Absolutely. But that's one of the beauties of what we're discussing now. I mean, we can share this message all over the world thanks to the Congenital Heart Academy. We can discuss it, and when Sarab and I discuss it, we'll happily answer any questions and comments that people have. But as you say, if it stands to sense that if something is inappropriate, we have to correct it. We can't continue promulgating something that is manifestly incorrect.
Correct.
And the great thing is that all of these is recorded, so we can take a look again and we can share with our colleagues. So the knowledge is going to be better shared with everybody.
Thank you very much, Bob. As I said, I have to leave now. I'm sure you've got interesting questions, and I thank you and Sasha and Grace for allowing me to participate in these most wonderful and interesting discussions. So have a nice.
All of these very rich.
I'm sure everybody's looking to you doing pulmonary venous connections on Monday. So I hope you're now recording them yourself.
Yes.
That's good news.
Okay, Bob. Thank you.
Bye, Norman.
Bye-bye, Dr. Bye-bye, Dr. Silverman. Dr. Anderson, we have some questions, interesting ones. So let's try to answer. So we have two questions about the humeral diverticulum. Do you want to talk a little bit about it? So one of the questions is talking about why, when it's calcified, and what, sorry, why the humeral diverticulum, an abnormal structure, calcification, and abnormal wall. And this is not always the case in the distal part of the double aortic arch. And the other question about it talks about does the humeral diverticulum could become aneurysmatic, so it should be addressed at moment of surgery?
Very good questions, and in fact, nowadays the people who visualize these things look at them and can see them in far better detail than I ever could when I was looking at specimens. We've just done a detailed study, in fact, of the data of the cohort at Birmingham Children's Hospital, and we've two of the BSc students who were working with Adrian Cruchan did a very elegant study of the cases of vascular rings in Birmingham. They examined over 200 cases, and the speakers, the people who are posing these questions to me, rightly point out that you don't always have a Commerle's diverticulum. And as I briefly mentioned, the inference to be made, and this goes all the way back to another wonderful embryologist, anatomist, pediatric cardiologist, Lodewijk van Meerop, who worked at University of Florida in Gainesville. And he did some work quite some time ago now with Lynn Cucci. And they pointed out that when you have the diverticulum, you can make the inference that initially there had been an arterial duct on that side. And it's an indication that probably there is an arterial ligament on that side. So if you don't have a diverticulum, the inference you can make then is that the duct on that side has disappeared in its totality. And then the subclavian artery will be of comparable dimensions throughout its course, throughout its origin from the descent. It'll still be the last branch of the, if it's a retroesophageal right subclavian, it'll be the last branch of the left arch. If it's a retroesophageal left subclavian, it'll be the last branch of the right arch. But if there's no diverticulum, you can make the inference that there will not be a cord present on that side because the duct on that side, the pulmonary arch artery on that side will have disappeared in its entirety. Now, the question about the calcification, that's a very good question. And I don't really know the answer to that, but the inference I would make there is that if it is calcified, that would suggest it was initially a diverticulum and that there had been something there that was blown out, that was more dilated, but I say that off the top of my head. But certainly the other point made, if you are operating on that, then I guess, well, Grace, you probably, you know more than I do about this. Or is Sasha still with us? Is Sasha disappeared? Maybe Sasha, what would you do? What would you do if you found a Comrose diverticulum? Would you try to resect it?
Yes, 100%. We don't really like it depends, of course, again, about the age of the patients. I'm sure that when you have, sometimes you will have some very bad ligaments across that can cross the diverticulum. So we want to be safe. Of course, we mobilize, but if it's very prominent, we like to reduce the size. It depends on the age, and it depends how much you make trouble. It means compression or make some double aortic arch or things like severe compression of the esophagus, at least, and of course the trachea. What is your idea?
I think we have Adrian Crucian with us, do we not?
Yes, I will ask Adrian to intervene live if you is okay.
Adrian, can you join us?
Yes, I will make it.
He says he has no microphone.
Our topic is
so has he sent us a message?
Yes.
Yeah, he's saying that he prefers posterior aortopexy, and unfortunately he can't join because he has no mic.
Yes, I agree with him, but again, it's case by case. We cannot define a sort of unique treatment for this type, because sometimes when we saw, I did one case was a symptomatic as neonate. You never see patient be very symptomatic as neonate, and there you have a very huge enlargement. It means dilatation of the comeral. So what you can do in this case, we clamp it and we remove it. This was the choice. But if we want to consider one treatment for all, I don't believe that we can do this.
And when you go in, Sasha, do you always look, if you find one cord, do you always look for the second cord?
Yes, 100%. We don't like, we can have, of course, Bob, now I can say that diagnostic tool can help a lot, pre-op. But before the introduction of this, I'm not talking now, but 10 years ago, I'm sure you can have bad surprise when you open the chest or when you close the chest and then you found it after in the follow-up. So I think I learned, I was, trained that you have to search all the possible connection between, comeral or additional ligament with the descending aorta. This is what.
And to me, that is the beauty of the Edwards hypothetical arch, because if you understand the double arch, you know what the options are going to be. And I think you have to bear that in mind all the time. And I think it's an amazing hypothesis. As I say, when you think that he produced it way back in 1948, there was no fancy CT or MR, or anything to look at then. And he did it exclusively on the examination of the specimens that he had before him. And he was an amazing cardiac pathologist. He did so much, he taught us so much. And he wrote the pathology chapter for the textbook that has disappeared now. It's published by Charles C. Thomas, Gould's textbook of pathology. And the Edwards material in there is quite spectacular. He was an amazing pathologist.
We have a couple of more questions. There's one question talking about tracheomalacia that is actually very interesting. She's asking, or he's asking, some rings are associated with a tracheomalatic segments, but not all. Any explanation for the selective effect of the trachea?
I'm not sure that as I say, I don't know a great deal about vascular rings, and I certainly would claim to have no expertise on tracheomalacia. But Sasha, do you know anything about that?
I think that again is a sort of case by case. It's something that we found. I think that the worst is the neonatal period, because generally you can have lesion directly from the fetal period, and this would be the worst clinical course. And generally you have tracheo or bronchomalacia. Generally you have the third part of the tracheo that is malatic, so you can have very bad outcome with failure in autonomic ventilation, so you are not able to extubate the patients. So I think that again, we are facing mostly of the case as a neonate, and when it happens as a neonate is a completely different situation. But of course, I learn also from you, from what you show. We met a lot of different places of malacia. You can have tracheo, you can have right bronchus, left bronchus, isolated left, isolated right. There is not a real, because it depends also on the position of the arch, because you can have right aortic arch, left aortic arch, and in this case, everything can found different balance in the mediastinum. So I can say the worst situation is when you have a tracheomalacia, and is the lower part of the trachea, and this is a very bad outcome.
These patients, that they need long-term positive ventilation, positive pressure ventilation. You can try in some of these patients, depending on the anatomy, to stent the trachea or the bronchus, but it's not easy to be done, and not a lot of centers can do that. Here we do, but we have the ability to make the stents for each patient. So this is something that we have been doing for this tracheomalacia and bronchomalacia, but it's difficult. Even then it's difficult to deal with these patients, even when we stent them.
I note that Adrian is posing the question, can it be that the right pulmonary artery arises from the left pulmonary artery? And that was a mistake in my slide, but I see no reason why. If the left can arise from the right, it must be feasible from the right to arise from the left. That it's a thing I am unaware of. Well, have you ever seen the opposite way around, Sasha?
Sorry, I never seen.
Oh, Grace, have you seen that? I guess the answer to that is we would have to Google it. We get the answer most times now if we Google something. But and if Adrian doesn't know, he knows as much about this as I do. So, but it's a good question.
Adrian can type the answer rather than the never seen.
Never seen. Yeah.
There we are. So
we can say 100%.
But someone somewhere might have seen it. We've still got 132 participants. Has anybody ever seen the right pulmonary artery arising? It must be feasible. If it's the other, that sometime at some place somebody is going to describe it.
Yeah.
I see we had another question that was quite interesting. That you can answer this, Sasha. Should we operate if the symptoms are mild, very mild dysphagia? I mean, that has always been the problem, has it not? When should you operate?
I think that there is a sort of consensus for this point of view that the symptom must be very sustained. It's not a sort of cosmetic surgery. Mm-hmm. As Paul Kekya said, there is nothing that we do, we cannot pay a second price. So in our experience, we used to treat patients that are very symptomatic. Of course, we cannot wait cachexia or other things, but the symptoms must be present, and of course must be sustainable with some exam diagnostic.
There's a question there. Some surgeons just ligate. That would not be good, would it? Because by ligating, you if there is a ring, you have to divide the ring.
Yes, ligation is not permitted as a PDA. You can ligate PDA, not double up.
And I think with this, we answer another question that's saying that if the patient is asymptomatic, if we keep it on conservative treatment, that's what we usually do. We only operate if the patient has at least moderate symptoms.
Yes, I fully agree.
It must be a worrisome thing, though, because it's not going to go away, is it? The ring is there.
But sometimes the patients, they tolerate that very well throughout the entire life.
Yes. Okay.
Okay.
So
amazing session, right?
Yes. Thanks, Bob. It was amazing.
Okay, so we will rejoin again on January the 8th, and I wish everybody a happy festive season. Hopefully COVID will begin to recede, but I can't see it receding before at least spring. So I fancy we're going to be continuing our activities through January, February, and March. And then Grace and Sasha will be judging whether the Congenital Heart Academy needs to continue irrespective of COVID.
Yeah.
I think that's going to be the case. I think we are giving amazing information to so many countries and to so many people that were not able to travel or to participate in big meetings. That I don't think only COVID
is the most amazing thing to me.
Yeah, it's amazing.
As to how much we are able to achieve now without traveling, and I guess by not traveling, we are improving our carbon footprint is much better if we do it all by Zoom rather than by air travel. The only downside we don't all get together.
But what about the wine after the meeting? We miss that a lot.
Indeed.
Yeah, to be with people is
to
very
be
important as well.
again, Sasha.
Yes.
Okay, guys, thank you very much. See you everybody on Monday with Dr. Silverman's session. Okay, thank you very much, Dr. Anderson. Bye-bye, Sasha.
Okay.
Bye.
Happy Christmas.
Thank you
For
very
all
much.
of you as well. Bye-bye.
Bye.